On May 18, 2020, there was a regular Colling County Commissioners Court meeting in McKinney, Texas. One of the agenda items was an update about the new Texas Department of Health and Human Services directive for COVID-19 case definitions. In the example used in this video, we will see how one confirmed case can now inflate to 17 cases using this new directive. So is this the reason why case counts in Texas is spiking?
At this time, I would like to have a conversation under the same header of COVID-19 update. We'd like to have a conversation and a presentation on the Department of State Health Services case definitions. The state of Texas, DSHS, has informed public health departments that they have adopted a revised definition for COVID-19 probable cases. And so we've invited our health department staff to come and give a presentation today and inform the court and the public about this new definition. Aisha, how are you?
Good, how are you?
Thanks for joining us.
Yeah, no problem. Again, my name is Aisha. I am with the epidemiology department with Healthcare Services. So this is a brief explanation on the changes that have been made to the COVID-19 case definition. So this image here will show you the current case definition. We did bring printouts if you guys would like those, or if it's, yeah.
Sure.
Thank you, Aisha. So currently, a confirmed case of COVID-19 was considered confirmed if there was a positive PCR lab result for COVID-19. Meaning if they got the swab testing done and it came back positive, that would be what we counted as a case towards COVID-19. If you didn't have lab results, if you just had symptoms, we could not count you as a case. So regardless of the contact you may have had with a confirmed case or symptoms, if there was no testing, you were not counted as a case. So in this image, we have the confirmed case and their possible contacts. And the total cases out of this is only one. And then if we go to the next page, the new case definition. So for confirmed case, it stays the same. You still just need PCR. But now they've added a probable case definition. So that still gets counted towards the case count. It's different. It's not confirmed. It's probable, but it's still a case. Meaning if you use another testing method, not PCR, and if you have close contact with a confirmed or probable case, and if you did that lab work that was not a PCR, you could be considered a case with or without symptoms. They also updated the definition for deaths related to COVID-19. Previously, prior to this definition, it was only if you had a positive PCR result that you would be counted as someone who died related to COVID-19. Now that lab testing is no longer required to be counted towards that. So that's just the language for the definition, and this next slide, the new probable case definition. So
Can I just ask a quick question? So back on the previous page, the new probable case definition with FDA-approved positive lab with or without symptoms, do you also have to have the positive lab along with close contact, or is the close contact with confirmed or probable cases a separate identifying thing?
So I'll explain this further.
Okay, sorry.
Yeah,
okay.
No. It's just an overview, gets kind of confusing. So this is the different options that we have for probable case definition. So if you do the FDA-approved testing, which right now is serology, looking for antibodies, IgG, IgM, you have to have the clinical criteria. And if you don't have that, and then you have the EpiLink, then you could still be counted as a case. So if we look at the yellow box here, that's the approved testing, right? If yellow, you have the test, and then you have any of the blue, you're a probable case. If you're yellow and you have any of the close contact, which doesn't mean you're sick, you're a probable case. And then if you don't do any of that lab work, and then you get sick and you were a contact of a case, you are then counted as a probable case. So The clinical criteria that they have defined is at least 2 symptoms of fever, subjective or measured, chills, rigors, myalgia, headache, sore throat, new smell and taste disorders, 2 of those, or 1 of cough, shortness of breath, difficulty breathing, or evidence of pneumonia without an alternative diagnosis and severe respiratory distress. So there's many ors and then there's many ands. So in order to be counted as, to see if you meet the EpiLink definition, you have to be a close contact of someone who's a confirmed case of COVID-19 or a probable case, or you came to a location where it's endemic. Right now, Texas has stated that they are considering the state as an endemic area. So that means if I just went and got serology testing done with no symptoms and I was positive, whether it's saying that recent infection or current infection, my new antibodies, or it's like I've had them for a while, I would be counted as a probable case. So basically, these 3 boxes, you can be yellow and blue without green to be counted as probable, yellow and green without the blue, and then blue and green without the yellow. But for the blue and green, if you had contact, that has to be within 14 days. So let's say activity dies down, slows down, and we're not considered endemic. Then we need that 14-day. But right now, that 14-day doesn't matter. Moving forward, it may, when activity slows down. So at the end of this definition, there are 15 different options on how you could be classified as a probable case.
Before we go into from the 15, you're talking about the expansions?
Yeah.
Is that what you're about to go into, the probable expansions? Or are you
So-
talking about the variables here?
These variables, there's
Okay.
15 ways to.
Yeah, let's go into that then, and then we'll ask questions.
Okay, so that same scenario, a little bit more extended. Now, if we look at it with the new probable case definition, where some individuals had the FDA-approved testing of IgM, IgG, some individuals just had contact with someone who is classified as a COVID case, whether they are confirmed or probable. So at the end of this, based on this diagram and what they report, there's a total of 17 cases now. 1 is still only confirmed because that was that original index case, who then had all these contacts underneath in orange. And all the rest of them became probable, but they are still considered a case. So.
Very good, thank you for that.
Yeah.
So, just to recap, this has the potential to be a very significant event for us here in Texas and here in Colling County, as the state now has elected to adopt this new probable definition. And if you'll go back one, Mr. Billiou, as it's displayed there on the chart there, the yellow box, the blue boxes, and the green boxes. If you have any 2 of those 3 colors, then you will meet the definition of probable. And in the yellow, you even have a positive IgG, IgM, or AG test, any of the antibody tests, then that satisfies that. And then the blue, the different clinical criteria to satisfy the blue boxes. And then in green, the epidemiological linkage criteria to satisfy the green boxes. What's remarkable is if you were to talk about all of the options there to meet those different boxes, perhaps the lowest hanging definition or combination is one that satisfies the epidemiological linkage by residing in any area where there's sustained ongoing community transmission. And as Aisha explained, that right now Texas is considered an endemic region. So all of the residents of Colling County already satisfy the green boxes. By virtue of the fact that they live in Colling County, they already satisfy the green. Now they only have to satisfy one of the blue boxes or one of the orange-yellow boxes, and they will be considered probable. If you look at the blue boxes, now, again, we talked about the orange-yellow boxes. That's a test, an antibody test. But if you look at just the blue boxes, if someone has 2 minor symptoms or one major symptom, that qualifies. So 2 minor symptoms, fever, headache, sore throat, chills, and fever, by the way, can either be measured fever or subjective fever. They just feel like they've got a fever. If you have a subjective fever and you have a headache and you live in Colling County, you now meet the qualifications to be a probable COVID patient. It is remarkable how low the standard is now. Mm-hmm. If you have one of the major symptoms, you have a cough or you have shortness of breath, and you live in Colling County, then you can satisfy the definition for a probable COVID case. So I don't think it can be overstated here that how much this could be taken out of context and could be giving a false narrative to our citizens and to our community. I'm not saying that we're going to see the numbers jump, but I'm very concerned that we absolutely could see the numbers jump very rapidly in a way that actually is not indicative of what we're seeing here in the community in the public health department. And so I fear that this is coming at a time when we're just now starting to reopen, and if the numbers jump in a false way, it's going to start to be very concerning to our citizens that we're actually going backwards. And so we've talked about this all this last week with the health department team, that the state has assured us that they're going to be reporting positive confirmed tests and probable cases and confirmed cases separately. So we take them on their word on that. Then from now on, they're going to be separating those into 2 categories as they report how many COVID infections they have. And the probable cases, because we won't know for any particular probable case whether or not they actually had a test and had the orange yellow box, or whether they did in fact meet the standard that I just talked about, the chills and a fever, and they live in Colling County. We won't know what boxes they satisfied. So the probable cases could be highly overstated and less reliable, certainly, than having an actual test. And then, so Mr. Billy, if you'll go forward one slide. I think this is critical here, and you talked about this, and thank you for that. This is the potential impact for us, just as one example of showing what could happen. The yellow person there is the only one on the board who has a positive PCR test. It's the only one that's tested positive with a true swab test for COVID-19. All of the orange boxes are coworkers and family members and neighbors and friends, folks that have had some kind of contact with the confirmed case. And as long as they can satisfy, and again, they all satisfy the green box. So as long as they can satisfy one of the blue boxes or the orange box, then they are all considered a probable confirmed case. So whereas right now, all of our resources in the public health department go towards tracking, reporting, and then contact tracing the confirmed cases and the PUMs, which is represented by one individual on this chart, that could be expanded 16-fold here on this one chart, just as an example of how it could happen. Now that could be overstating it. It could only expand 10-fold or 5-fold, but we have the potential to see a remarkable expansion of those that are considered COVID positive. And if you're just doing that for reporting, well, it's not reliable, but if it's just on paper, then we all can just commiserate about how unreliable it is. However, we would have to now spend resources to do contact tracing for all of those folks on there that are represented in orange, and call them every day to find out how they're doing, and then wait the 10 to 14 days before we can mark them as recovered probable cases. So it represents a remarkable expansion on resources for local public health departments across the state. And as it turns out, I'm not sure if either of you ladies wants to talk about the changes we're about to have with the state in that relationship, but it's probably a good time probably good timing that the state is changing that for us here this week. So that's kind of the critical part there, and we'll stop just for a moment about any discussion or questions about the chart or the presentation.
I do have a question. Just on this chart that the judge just mentioned, with the 17 total cases, 1 confirmed, and 16 probable. On the far left, there's a household, and they're positive for IgG, which, correct me if I'm wrong, because you're the professional here. My understanding is IgM is an active case. IgG is, you've had it before. So would these people be told to quarantine because they had an IgG test?
So right now, as far as what measures are being done with asymptomatic from date of test, so if this will get an investigation, basically you should wait 14 days from date of test to be clear of any sort of possibility of still spreading. So IgG, IgM, yes, there is recent infection and then past infection,
Right.
but sometimes that's not always true. So if they're doing serology, that means that they had that exposure that was detected in that test. So just, precautionary to wait the 14 days from that test. Let's say they were a healthcare worker. They would need to wait 14 days from that test day because they got some sort of diagnostic test to say that they've developed some sort of antibodies. So it's possible. They haven't really provided guidance on how much restriction there is going to be on movement when you're serology positive versus, IgG versus IgM. But I think they will be case specific if it was a healthcare worker that does pose a threat to that population that they're taking care of.
Well, let's ask the same question from a different angle. Let's take the serological test out of the equation and just focus on the blue and the green boxes. Mm-hmm. If you worked with a coworker who has now tested positive, and so you absolutely, you reside in Colling County anyway, but now you actually had somebody that you know of from your work who tested positive. So you've got the epidemiological linkage for the green boxes. If you come down with a fever and a cough, you absolutely meet the definition of a probable case. Yeah. Are you required to quarantine for 14 days?
So if you're a contact of a confirmed case, which is what you're saying, my coworker is positive now, that's a case confirmed or probable, either way. You should then yourself watch for signs and symptoms.
Everybody should, just in general, always watch their own health,
yeah.
Which is what we tell them today, as we call all those PUMs, persons under monitoring.
But right now, if you're PCR positive, for anyone that's considered to be a close contact, they should stay home for 14 days. I don't know how they're going to translate this for serology. So if you're a confirmed case, if we spend 3 hours here, you guys are considered my close contacts. 14 days from that exposure from today, if I'm positive, you guys should stay home. Should, is the key word.
What do you see as the benefits of changing all those case definitions at this point? I know it's not Colling County doing it, it's the state, but my big question is why? I mean, it seems like it's going to artificially inflate cases in some instances. It might catch some actual cases in others, but we don't know 100%, it's just probable and likely. We haven't even gotten into the death certificate aspect yet.
Yeah. And for that question, when they originally released this definition through the territory of epidemiologists for the state, the council of that, and that's who epidemiology takes from at the state level. That was back in April, mid-April. So we knew there was a possibility of a definition coming out. Texas didn't implement it. Why they chose to do, this timeline, I don't even know if I could find an answer for that. So, on our list of criteria for reportable diseases for all reportables in Texas, we have roughly about 100 diseases on that list. Roughly 50% have a probable definition. But, if some of you have been talking to Candy, typically we get this at the beginning or early on when, a disease has been identified. We don't get it after, certain measures have been taken to prove that we're trying to slow down the spread. So why they chose, last week to release this formal definition, I don't know if anyone else has an answer to that.
So let's focus on what you just said for a moment. In an epidemic, in an outbreak in an area, it's common to have a probable definition in force early on in a response. Is that what I'm hearing you say?
So this is my interpretation of everything that has happened. You know, it started globally somewhere else. They developed a probable definition there. So it's likely that once it came here,
No, I'm talking generically. Generically, in an epidemic response, a probable definition
Yeah.
is more common
yeah,
in the early stages of response. Is that what I understood you to be saying?
I would say not at the beginning, but not at the end, not in the middle either. Because once you can develop additional lab testing, you know, you can classify a probable definition. When we first got this, we only had one way of detecting this in a lab. That was PCR. Now they've developed these new tests. So now they can create that definition.
So once you've gotten to the point of more widespread testing, it runs counterintuitive to this, that you would bring in a probable definition at the same time that you now have the most testing capacity that you've ever had. That seems to not match up well.
Yeah,
Is that accurate?
that's correct.
Okay.
So, go ahead.
So this is a little bit of history for the court. The definition, this probable case definition, was adopted by the Council of State and Territorial Epidemiologists back in early April 4th or 5th. They adopted this. They sent it to the CDC, and the CDC did take that recommendation and adopt it and send it out to the various states for consideration. And so now Texas DSHS has adopted this definition and will be using it. So there's a bit of a distinction here. Colling County is all of our counties here in Texas are about to hand off to the state our reporting and our contact tracing responsibilities. The state has used part of their CARES Act funding to hire a private contractor to take over contact tracing and to do reporting at the state level. There's been a lot of discussion as to whether or not that was, why that was done, or if that should have been done, but regardless, it has been done. And so where Colling County from day one has been doing, I'm just going to say, a remarkable job of reporting and contact tracing, even taking employees from other departments and retasking them and retraining them to do this task. Hiring 4 new epidemiologists to add on to our department. We've met the challenge head on, and I think our entire public health department should be commended for that. But the state now has a private contractor that's taking over this task. And all of the labs that are done for Colling County residents are going to be reported to the state instead of to us. So they're going to be accumulating all of these reports, all of this data. They're going to be then taking those reports and sending them or assigning them to the contact tracing individuals who will make the phone calls and guide people through their personal health response. So we won't be doing that. But if we were to continue to do this in the same way that we have been, while we've done a fantastic job of monitoring the response and responding to the outbreak in Colling County thus far, we are not well prepared to respond to a 16-fold outbreak. And that, you could argue that that's being very, very careful. If you just assume that everybody's a probable case, okay, great. Well, then we'll all stay home and we'll all wait 14 days. I mean, you could see that maybe that helps in the sense of controlling the virus. But on the other hand, if we're treating everybody like they are, then we've got to call everybody and we've got to make sure everybody is staying home. And it's a very dramatic response and one that we're not well suited for here at this kind of a definition being entered into the equation. So the state is taking it over. And I'm glad they are, as if they're going to enforce this definition on us, then they're going to have to find a way to respond to it and all that comes out of it. It's going to be very confusing for our citizens because we do a fantastic job reporting every day, the cases, the numbers. We're very transparent of everything that we're experiencing here. We share that with the public daily. But there's a potential that the probable case numbers are about to shoot up, and folks are going to see the curves and the trend lines are going to change, and they're going to have lots of questions. And that frustrates me because I know we're all going to work hard to make sure and get this message out, but despite our best efforts, it will be very hard to get in front of this story all across this community of 1 million people.
I agree with you. It's really frustrating that there's not going to be the data consistency. Are we going to have the ability to have cases that we have been counting exactly the same way and then have a different bucket showing the probable cases? Are we going to be able to?
They said that they would like to report it that way. The states that have already implemented this, they do report it that way. So I would hope so, because then it's counterintuitive at the state level.
Otherwise, all the data that we've collected to date, we can't compare it to anything. It's almost like we're starting completely over.
I mean, you look at one of these neighbors, the neighbor reports having a sore throat, the one in the middle, right below the confirmed case. They could have the flu, they could have the common cold, and
Allergies.
then their neighbor's family, they get, I mean,
I already meet with them. The moment I know someone,
yeah.
I'm there.
And
You live
all
in
of those,
Colling
none of
County.
those people in that stream have any kind of a test.
Because it might go on the death certificate is you died because of COVID.
And none of those people in this example have had any kind of a test. They just have some symptoms. And one person had close contact, which we're not even sure what the definition of contact is. I mean, you said 3 hours in this room with us, but how's the state determining contact? Are we in the same grocery store? You know, somebody's 2 aisles over, am I now a contact of theirs because I was there at the same time?
Yes.
They have defined that.
They do define that. I'm going to read this verbatim. Close contact is defined as being within 6 feet for at least a period of 10 minutes to 30 minutes or more, depending on the exposure. In a healthcare setting, this may be defined as exposures of greater than a few minutes or more. They say that because if you're doing an actual procedure in someone's mouth, you don't need to wait that 10 minutes. But, you know, anything more than that or less than that, it is hard to define. So 10 to 30 minutes, less than 6 feet apart. Yeah, for sure you too. So.
I'm just worried about the perception from the general public that's not watching us right now. They start getting stuff coming out over the media and just trickling out to them. It's going to make it look like there's ulterior motives to the case number and all. And absolutely not the case. We all have serious disagreement with reporting this in a different fashion after we've been doing such a good job today.
Correct. I think the perception's gonna be, the good news is it's gonna jump everywhere in the whole state. And it's not just gonna be us. But it's gonna be, if this is an example,
Yeah.
you're gonna see your culpable case count go from very small to hundreds and hundreds
Absolutely.
a day. And the public, it's gonna cause a reaction.
It is.
You're likely to
Cause
see
panic.
people, I mean, there's several reactions. You're going to have a certain level of people who are just as they were getting to be a little more comfortable, are going to be very fearful again. Some people you might have people who don't want to get tested because of the impacts of getting tested. They're going to choose not to get tested.
They're just going to lie and say they've not come in contact with that person in the past 2 weeks. You know,
Well, the
because
other thing is, I don't see how this irrelevant of who they contracted with at the state level. There's no way you're gonna have enough personnel to do 17 for each one.
All across the state. For those that don't know about this case definition, who don't understand it, when they see these dramatic increases in numbers, they're going to be inclined to think either that we've hit some different spike and now, quite frankly, we have this new pandemic raging through the community, which is a false narrative. That's not at all what that is sharing with us and communicating to us. Or they're going to be inclined to think, well, we weren't doing an honest job with the numbers prior to this. For those that do know about this narrative, that do know that the definition's been changed, they're going to have to decide for themselves if they even want to trust or believe all of the numbers coming out from government from this point forward. And if they immediately say, you know, I just don't trust these numbers anymore, they've changed the definition, they're off the charts now, I don't trust it. That doesn't help us from a public standpoint to put out numbers that the public are going to distrust. Doesn't work in our favor either. We're trying to communicate everything openly and honestly. Again, someone could make the argument that this is more communication, and I can understand that argument if the public understand what's going on. But this is such a technical decision that here we are sitting here, all of us following along on this story very intently for the last several weeks, and it takes a very technical presentation to get there. And I just worry that it's not going to be well understood, other than simply saying, don't worry about the numbers changing. They changed the definition. It's not comparable. It's not the same thing. Don't worry about it. And if you give a flippant answer like that, it runs right into that narrative of don't trust the numbers anymore.
And there's no guarantee that even if the state keeps these numbers separate, that media will.
That's
Or
absolutely right.
it gets disseminated to you.
That's true.
So there's just so many opportunities for there to be bad information being
Yes.
provided.
Yeah, I think, I was always taught, whenever I was taking my computer science classes, it's GIGO, garbage in, garbage out. You get bad data or subjective data poured into something, your results are then subjective. And
Everything's
very
skewed, yeah.
Skewed and flawed. And, just looking at the order of magnitude of the people that the state's going to need, I don't know, we were at 60, 80 people maybe at our peak of tracking, and we're talking about multiplying this out by orders of magnitude, and that's just for our one county. And the state's saying they're hiring 4,000 people, we probably could use 500, 600 people if we're doing this on our own, and we're talking about 254 counties. So I don't think there's any way the state can even handle what they're proposing the new standards to be.
It begins to make number of cases irrelevant, and you start to, hospitalizations are a much better
Yes.
number to look at as hospitalizations, and even deaths are going to be now no longer accurate either. So it's hard to follow deaths. I mean, really, hospitalizations is the only number that gives you some idea of what actually is happening.
Well, is it hospitalizations would probably, at that point, the world's going to
The death consideration is important as well. They've changed the definition there, or the requirements for a death from COVID. Do you have that slide with you today?
Yes.
You want to jump to that one and walk us through that?
The last page, yes, thank you. Okay, so based on this new definition for deaths related to COVID, so this white section here, the cause of death, is typically what we'll look at when, receiving anything from the ME's office to see how to classify that, if it will be related to a disease. So if they, report respiratory symptoms, never had a chance to do testing, if there was no testing done, you are not counted as a COVID-19 related death, whether you had close contact, whether you are in an endemic area. But now if they think that it's possibly related and they just list it as a cause, that will be counted. So no diagnostic testing is needed to be counted as a death related to COVID.
If the attending physician puts down COVID as the cause of death or a possible contributing factor of death, then then that patient will be considered a COVID-related death.
Without a test.
That's right, with no antigen test, with no serological test, no blood, with no PCR test. There is guidance, however, that if the patient died from some outside force that's clear to everyone, a car accident, for example, even if they were positive for COVID-19, it should not be, the cause of death shouldn't be COVID. But that's if it's well agreed upon that there was something else, some outside force that was the cause of death. Beyond that, someone dying, if it's listed here, then they will be listed as a COVID patient. And so that also has the opportunity for COVID deaths to go up dramatically.
Mm-hmm.
And it doesn't matter how they arrange these cause of deaths. Like in this example, it's listed at the third level. So it doesn't have to be first, second, third. They had so many underlying conditions. If it's listed, then they will count it.
What benefit is there for that? Just future tracking that they passed away in an area that was endemic to COVID?
I don't have an answer for that question.
There could be funding that's associated coming down the pike later. that the federal government may use.
Future funding.
Future funding coming from the federal government, that the more cases, the more deaths you had, the more dollars you'll get.
That's the only thing that makes sense.
It's the only thing that really makes sense.
Does that mean we're going to have to retroactively go back and then relook all of our cases, or are they the same from this point forward?
Usually any guidance that comes is moving forward. They don't want us to go back and reclassify anything. So that's a positive. I would like to go back to this one slide where we have 17 cases now, just to kind of explain the different boxes that they could have fit into. So we have the confirmed case, their household, they need the yellow and green boxes, and then the friend next to that household would be blue and green. The neighbor is blue and green. The neighbor's family is blue and green. And then the neighbor's coworkers, that's blue and green as well. The coworker is blue and green, and the coworker's family is yellow and green. So I do want to emphasize that this is not just limited to those that are the direct contacts of the confirmed case. Basically, everyone in orange is probable. So contact with a probable case could make you a probable case, which typically does not happen in our case definitions.
So I would just ask the court members, and I know you're all thinking this already, I'm going to be communicating about this to the county and ask you to do the same thing in your different channels, be thinking about how to communicate with your constituents on making this as clear as possible. We've been told the state is getting ready to take over the reporting and contact tracing functions for the county. We don't know what day, but our public health department is watching that very closely and is communicating with Mr. Bilyeu to let us know. And we expect that one of these days we're going to start seeing these positive reports from the state start to end. We get those throughout the day, every day, as lab reports come in. And we expect that someday, potentially this week or in the next 10 days, that those will stop or they will significantly slow down. And that'll be the indication that they're holding that information in their own system rather than pushing it out to us. And that'll also be an indication to us that the state is now taking that responsibility over, and we'll soon send all of our employees back to their departments, and the epidemiologist will then focus on other diseases in our community, as they always do anyway. And that'll be the change for us here in the county. We don't know precisely when, but it's coming. And then if the state wants to track a 17-fold increase in cases, that's going to be the responsibility of their new contractor.
Judge, should we take down our website then?
That's where we're headed.
It's not going to be accurate compared to the dashboard.
It's a great question. So we've already talked about that internally, that as soon as we see that, yes, the state is holding back the case data from us and using it in their own dashboard, as an example today, the county website dashboard and the state dashboard, they mirror each other. If you look up the county on the state's dashboard, they show the same numbers. But we are expecting that they're going to diverge at some point in the next 10 days where they're holding numbers that they don't send us. As soon as we see that happening, then yes, it is our intention to take down the county dashboard. I'm going to take down my reporting and stop reporting out daily, and we will all have to communicate. There will be questions upon questions of why aren't you reporting anymore? Why did you stop? And so we'll all have to answer that question 100 times that we aren't reporting because we're no longer given the data to report. The state is holding that data because the state made the decision to do reporting and contact tracing internally in their own department rather than having us do it in our public health department. And of course, the narrative there ought to be that they're doing that for the entire state, too. That's not something they just did for Colling County. They've done that statewide. So, yes, that's coming, and that's going to raise a lot of questions when that dashboard goes away.
Go ahead and add a warning to it now,
Yes.
so that there's some expectation that.
Needs to be, hey, this is coming, and then this.
On the
I would
dashboard,
suggest that we put this up.
On the dashboard itself.
Okay.
The public
Very
needs
good.
to know, I mean, we've said it here today, but this needs to be on our website so they understand.
Very good.
Thank you, Aisha.
Yeah, we're all going to get a lot of
States,
questions about it.
Dashboard for the states up there, very obviously, right up there as well.
We get a lot of calls, a
Uh-huh.
lot of emails